patient had a Moynihan sum during surgery. So this is my case. I'm operating this case. You can see I'm showing you an interesting sign here. What sign you are seeing here in this video? You are seeing here a picture like you see this. This is looking like a elephant head with the thing, no, that elephant like sign. This is known as Ganesha sign. Please remember, this Ganesha sign is coming means you are doing a perfect surgery. This sign is what we call it as Ganesha sign. So this looks like a elephant head, and this looks like a elephant's that have a limb. So it looks like elephant limb, and you can see a Kellard's node here, and I'm opening it, the cystic artery entering here. This is a typical critical view of Strasbourg. Now I am dissecting. No, at the time I'm seeing one abnormal artery here. I don't know whether you could note this. There you see, there is a dilated artery running like this here. This is a right hepatic artery running like this. It's a Moynihan sum. We rarely encounter this type of anomalies. So Moynihan sum. We should be very careful before clipping the cystic artery. So please remember, cystic artery or Moynihan sum can cause a confusion. You should be very careful before clipping the cystic artery. If there is some bigger artery during surgery, think of Moynihan sum. That is nothing but an abnormal tortuous course of right hepatic artery. So another important anatomy, as this is not important for MBBS students and PG aspirants, but this is a classical important line when you are doing practically laparoscopic cholecystectomy. The moment you put a port and you pull the gallbladder, push the gallbladder towards the fundus, you can see one sulcus here. This is a very, very important sulcus. This is the inferior most point. I should not go below this point. While I'm doing surgery, I should always stop my dissections, everything above. If I go below this point, I am dealing with the common hepatic duct, and this ruveus sulcus is always in 90%. You can see a ruveus sulcus during surgery. The ruveus sulcus contains right side portal triad. So ruveus sulcus contains right side portal triad, means that contains the right side hepatic duct, right side portal vein, even the right side hepatic artery. Right side important structures will be passing in this ruveus sulcus. So our dissection, everything should be above this ruveus sulcus. Many times what happens during laparoscopic surgery, we will not be knowing where is the inferior limit. We keep on dissecting, and we'll be going at this level inferiorly, and we may injure the common bile duct or even some vessels inside. So ruveus sulcus is the inferior most dissection point. The inferior most dissection point as a laparoscopic surgeon, you should always remember is ruveus sulcus. So this is very important for surgeons. This is a ruveus sulcus, don't forget. So one another important thing which always causes problem is while we are doing surgery, laparoscopic cholecystectomy, we will be clamping the cystic duct. I'll show you as a diagram, you'll understand much better. So sometimes there is one anomaly, very commonly seen anomaly. So this is the liver. Now I have pakka clamped the cystic duct. I have clipped the cystic artery also very nicely. I'm sure there is no other injury. I am going towards the gallbladder now. I am dissecting from below upwards. Like this, I am dissecting and going from below upwards. This technique is what we call it as retrograde cholecystectomy, but Bailey has given wrongly this as antegrade cholecystectomy. Actually, we call it as retrograde. From inferior, we are going above. So retrograde cholecystectomy is being done. So I will clip from here and I will dissect, and I am going like this. As I am going like this, suddenly what happens? No, from somewhere from the liver, small duct which can enter the gallbladder like this. That when I cut this, immediately there will be bile coming out. Sometimes we can find out during surgery itself. Sometimes only we find out there is a bile coming out from the liver itself. That is a duct which is entering directly into the gallbladder like this. That duct is known as ducts of Luschka. It is seen in 10% patients. 10% patients, they will have ducts of Luschka, and it is also known as subvesical duct. It is also known as subvesical duct or ducts of Luschka, which will enter into the gallbladder like this. So if I note it, I can put a clip during surgery. If I note there is a subvesical duct, I can put a clip, but 90% of the time we cannot note it. And post-operatively, what happens? There will be a bile collection in this place. From the cyst of Luschka, there will be bile coming out and it will form a collection in the post-operative period. And this is known as bilioma. So bilioma is nothing but an injury to the bile duct resulting in bile collection in the right hypochondrium in the post-operative period. So this bilioma, the second most common cause, I'll tell you about the most common cause later while discussing bile duct injury. Second most common cause of bile duct leak is known as due to ducts of Luschka. Ducts of Lushka, what to do? If there is a leak from ducts of Lushka, nothing to worry. It will stop by itself. It will stop by itself. So ducts of Lushka can cause bile collection in the postoperative period, and we will be very much scared to see a bile collection always. As a surgeon, will be always stressed, and we will get sleeplessness when we see bile in the right hepatic, subhepatic region in the postoperative period. So bilioma is a dangerous problem we always face. That is the only complication I will explain to the patient. So the only thing I will tell to the patient is there may be chances of bile duct injury and leak in the postoperative period, and that may need intervention. This is what we get in a concern for all lap cholecystectomy. And the second common causes this bilioma. So we'll discuss about bile duct injury at the end of the session. So this is important thing. You should not forget ducts of Lushka or subvesical duct. Where is it connected? Means it is connected somewhere to the right side duct. I'll show you. It will be connected somewhere to the right side duct. Can you see? This ducts of Lushka goes from gallbladder to somewhere to the right side duct like this. It's a connection. It's an accessory duct. Okay. So you can see the various abnormalities in cystic duct. So many abnormalities are there. That is why my professors, when we are going for a training, they always tell us, don't try to dissect the cystic duct up to the junction. Cystic duct CBD junction, we will never dissect up to this place in laparoscopy. Cystic duct CBD junction, we never dissect. We dissect only the gallbladder with cystic duct and we put a clip there. We will not try to remove the entire cystic duct. See this patient, for example, see the D. If I try to dissect and go, I will have to go and put a clip here. It is a low insertion. If I try to dissect here, it inserts on the left side. I have to go to the left side. I can injure the CBD. In the C and C, you can see there is no duct at all. In F, you can see an accessory duct entering the cystic duct. So E, you can see a fused duct. So we have to clip at this place itself. We do not try to dissect them. So the point is, when we are putting a clip in the cystic duct, where should I put a clip? I will always try to put a clip close to the gallbladder. There is nothing wrong if you are going to leave a long length of cystic duct. Long length of cystic duct, if there is there, it is going to be remaining there. Ensure there is no stone inside the cystic duct. That's all. If there is stone inside the cystic duct, it will cause problem. If there is no stone in the cystic duct, you put a clip always at the point of gallbladder with cystic duct junction only. Always, you should never be over smart to dissect the cystic duct and go up to the cystic duct CBD junction. Is a wrong place to go and put a clip. Never ever do this. Always put a clip at cystic duct CBD junction, so cystic duct gallbladder junction only. That's enough. Ensure there is no stone in the cystic duct. You just try to milk and see there is any stone. If there is no stone, you can directly put a clip in this place and that will be enough. So this is very important, cystic duct anomalies. So this is okay. Cystic duct anomalies we will face and we will mostly cure them. But the problem is with the right duct anomalies. There is a classification known as Hume et al. Classification. If you see this classification, you will always have a scare to do a laparoscopic cholecystectomy. That much important classification. See the classification. The first one is only 62%. This is a normal case. Normally what we have, right duct, left duct. Right duct has right anterior sectoral and posterior sectoral. This is a normal anatomy seen only in 60% of the patients. So this is a cystic duct gallbladder. You are lucky if you are getting an anatomy like this, type A1 as per Hume et al. Classification. You are lucky even if you get a type A2. In A2 also, it is a trifurcation. They are all divided into three. They divide into three. See, left hepatic duct, right posterior sectoral, right anterior sectoral. There is no disturbance in this anatomy. You will cut. So in type A3 also nothing to worry because right posterior sectoral duct is going to come from left hepatic duct. So nothing to disturb in Kellogg's triangle. You will be only concerned with the Kellogg's triangle. See, I will be concerned only with the Kellogg's triangle. In A1, A2, A3, there is no problem in Kellogg's triangle at all. So we are least bothered about the first three anomalies. But you come to the fourth one. See the fourth one. There is a problem happening. The fourth one, you can see the right posterior sectoral duct entering into the cystic duct. If I clip it here, now you see, if I clip this at this point of place, there will be more problem. Many times what we think is when we see like duct like this and duct like this, we always think it is a CBD. We have put a clip in the CBD like that. We think actually it is not CBD. We have put a clip in the right posterior sectoral duct and in the cystic duct like this. So in the type A4, 5.8% is a dangerous anomaly. Dangerous anomaly. We think this is a cystic duct and we put a clip here. Or sometimes even during surgery, you'll think it is a CBD. So when there are more than one duct entering towards the gallbladder, you should be always very careful. Now you can understand why I'm telling you always to put a clip close to the gallbladder. Why I'm telling you always put the clip close to the gallbladder only. You're not doing surgery for a malignancy. Please remember, you're doing surgery only for a benign case. Always put clip at the cystic duct gallbladder junction. Nowhere you will get a problem. In whatever anomaly, you will never get a problem. If you're putting a clip in gallbladder cystic duct, there is no problem at all. So even for A5, there is nothing to worry. So the concept, the basic concept is always put a clip at gallbladder cystic duct junction. Don't try to dissect too much of cystic duct. If you try to dissect too much of cystic duct, there may be anomalies getting injured. The cystic duct can go for various issues. So please remember this. Always put a clip at gallbladder cystic duct junction. So this is a video showing you the critical view of Strasbourg. So in this video, you can see there is a critical view of Strasbourg shown. So this is how I am seeing with a 30-degree camera from inferiorly. See, this is anterior view. The Lord Ganesha sign you are seeing now. So Lord Ganesha sign, this is a Lord Ganesha sign. You can see it looks like a elephant's. This anatomy is like a elephant-like appearance known as Lord Ganesha sign. When this sign is coming, when you are dissecting, you are in a safe plane. You are in a safe plane when this sign is coming.